diffusion system, and this can cause local site
Good
infections like
afternoon.
phlebitis or cellulitis
Is it
or
audible, ma'am?
related bloodstream infection to the patient. The commonest microorganisms is Staphylococcus aureus, Cones, Klebsiella, and Pseudomonas. How this infection comes in?
Uh,
So it can because of poor hand hygiene, improper skills,
Hello,
preparations,
is it audible?
undiluted devices, failure to disinfect the port, undiluted fluids, medications or equipment, use Dettol soil dressings, repeat unnecessary lines as patients have multiple levels of
Um,
incubators, prolonged
Loveleen, ma'am,
retention
is
of
it audible?
supplements. Then how germs build
Hello.
up through the IV system? It can through the skin. Germs enter from the skin. The skin. Um,
Hello, Surbi, can you hear me?
Yes, ma'am. You're audible.
Yes. Okay, thanks. Actually, somebody has accidentally, uh, I think, started the meeting. So whatever we are doing it's right now live itself. Usually, we have to start it once the audience are there, but never know. We can just have an AV check from our side, like from the speaker side. Good afternoon, Lavleen ma'am, Minati ma'am, uh, Kumkum ma'am. Good afternoon. Hi, Miss Pooja. Is it audible?
Yeah, it
Hi,
is.
Hemanti. Yeah, hi.
Hello, ma'am.
Right. So we can just quickly check our video and audio so that we are clear. Like there's no problem in the connection or something. Uh, Vidya, is it you? I mean, we haven't met yet. Miss Vidya, uh, boardroom Noida, is it Fortis itself? Hmm. Okay. So you may want to share your screen. Hemanti, you want to check it first?
I want once.
Right,
Just
right,
a
right,
minute.
right.
Hello
And Surbi,
everyone.
hi ma'am.
Good afternoon.
Good afternoon.
Good
Uh,
afternoon, ma'am.
Surbi, you'll be sharing the presentations for the introductions, right? Hello, Surbi, is it audible?
Yes, ma'am. Yes, ma'am. Yes, ma'am. I will.
Okay. Fine. Great. So fair enough. That control is with you. Um,
Yeah, good evening, everyone.
Hi, good evening, ma'am.
Hi, good evening, Anna. Good evening. Hi, lovely. Hi.
Good evening, ma'am.
Hi, good evening.
We were just doing the AV checks, ma'am.
Mhm. So I've got all the panelists here.
We have Hemanti is there, Kumkum ma'am is there. We see Pooja is there. And 1 second. Priyanka is also joined in. Priyanka, you may want to switch on your camera. And voice check also. 1, 2, 3.
Hi, good evening.
Okay. Yeah, this is mandatory steps here because before we start, no, so all of us should be quite properly audible and visible. At the same time, you may want to
can hear you.
yes, you may want to share your screen also once so that we rule out any chances of any technical glitch or something.
I don't have a slide, Pooja, but the panelist introduction, I think you will project, right?
Yes, 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 ma'am. Surbi would be doing that. Surbi is there from my team. So
Shall I share that, ma'am, right now?
just
Yeah, I
try
think that will be good. Yeah.
just try sharing it once.
So I just quickly want to check. Dr. Farhan is not here, right?
No,
In the
Dr.
call.
Farhan, yeah, he is not there yet.
Miss Vidya.
Yes,
I-
ma'am. Good afternoon.
She's there. Boardroom Noida.
Boardroom Noida.
Yeah.
Okay. Miss
Yes.
Kumkum. Yeah, she's there.
Yes.
Miss Priyanka and Miss Pooja.
Yeah, Pooja is also there. I think she's not. 1 second, I'll check also. You can just move the slides, Surbi. Try moving it. Ah, 1 second. Surbi, just stop sharing it once.
Pooja, you've mentioned one Miss Hemanti Chaudhary, but she is not in my list.
Hemanti, she's the QIP presenter, ma'am. So
Okay.
for her there won't be. Yeah.
Okay.
She'll be towards the end. So she's presenting the QIP.
Okay.
Excuse me, ma'am. Should I share my slide once? Just want to see whether.
हाँ हाँ and Vidya आप एक बार ना अपना कैमरा भी एक बार जरा adjust कर लेना when you were talking no it was your face was not visible just check that as one. Good afternoon, Dr. Fan.
I know.
Yes, now it is fine.
Yeah. So I just wanted to check with all the panelists. I think you've all got the questions. I was thinking rather than going from one panelist to another panelist, because the way we have categorized the whole discussion is into sub main topics. So I was just thinking maybe I can finish the first set of questions with Dr. Farhan, and then I move to the next speaker, so that it kind of gets finished in a sequential manner. Is that okay with everyone?
Yes, ma'am.
Okay, so you must have seen that there are some 3-4 questions that I have given. So I will see based on the time availability. Definitely, you will get 2 questions for sure. And if the time permits or the response of your questions are short for the first 2 ones, then I will add on the third question. And in the last, there are some rapid fire questions. I will ask very randomly 1 or 2 people to answer that. Okay, right. Thanks.
Also, ma'am, the speakers have a few content slides as well. So if because that is for the audience itself who are watching it online, no, for making their connects itself. So they can share it if it supports the link, when it's in alignment with the topic itself. So they can share it as well, no?
Yeah, they can, as long as it is in line with the question that is being proposed. I think that should be fine. And I think very important request to everyone that let's try to adhere to the time slot, because each speaker will not get more than 8 minutes. Because if somebody speaks for say 15 minutes, then it's taking away time from the other speakers speaking slot, which is not fair. And I don't want to be in a situation where I barge in and try to stop it. That would be the last thing I would want to do. So let's be very mindful of what we will speak and how much we will speak. Yeah.
Right. So we'll be starting at 3:30 sharp. So we may switch off the cameras now,
Okay,
no problem. Just for AV check. Yeah.
Okay.
Hi. Hello.
Yes, Hemanti.
Just can I try once to share my PPT?
हाँ बिल्कुल करो ना आप आपका वाला share कर लो, because for you it would be completely the QIP only. Yeah.
Yes, ma'am. ये एंटायर स्क्रीन में शेयर करना है कि विंडो पे शेयर करना है?
आप विंडो शेयर कर लो. Just share the window and then select the window in which you are. आपको options दिख जाएंगे जब window share करोगे ना.
हाँ.
Because screen में sometimes some office work is also there. You may not want to show that. Window में आप select कर लो. You'll be seeing that option in the side. नहीं इसको तो unshare करो एक बार.
स्टॉप शेयर.
हाँ इसको stop share कर दो. जब आप विंडोज पे सेलेक्ट करोगे ना, then you will see a number of windows will pop up. When you select windows ना, then you will see number of screen would be popping up. Now select the one that you want to share. दिख रहा होगा वहां पे 1 2 3 4 करके लाइन से कुछ स्क्रीन्स ओपन हो गए होंगे विंडो में. अगर ना हो पा रहा हो तो फिर वापस फिर आप स्क्रीन शेयर कर लेना. सिंपल जो लगे, कंफर्टेबल जो लगे.
ओके.
ठीक है, ट्राई कर लो एक बार, अभी टाइम है. think this is Vidya's presentation, which we are now
No.
seeing.
Yes, ma'am.
So you want Vidya to stop sharing it and then you can share, I guess?
I guess that will be right.
Yeah, now you can share it.
Okay. Is it visible?
Yes, it is.
Thank you so much.
Very good afternoon, everyone. Respected speakers, Pooja.
Good afternoon, ma'am.
Hi, hi.
So
Hi.
I have prepared some slides. Shall I also try to put on sharing mode?
हाँ हाँ एक बार आप check कर लो.
My sound is audible?
Yeah, it's clear, crystal clear.
Okay. Is it visible?
Yeah, it is visible. You may want to put it in the slideshow mode, I guess.
Oh, okay.
Mm-hmm.
Is it okay?
नहीं हम लोग को अभी भी वैसा ही दिख रहा है सेम. हाँ, now it is fine. So I guess all of us have tried sharing our screens as well. So there should not be any challenge on that part. बाकी कुछ भी रहता है, then you can always, we are there, like Surbhi is there, Akshita is there, and Jayashree would be also there, and Anjali would also be there. So कुछ भी रहता है, you can reach out to the respective box.
हेमंती का हो गया था शेयर
हाँ, yes ma'am, हेमंती ने
था।
share कर. हाँ.
Who's there in boardroom, Noida? I'll just make a note of it.
This is Vidya ma'am. Vidya
Vidya,
is there.
okay.
Yes. I'll put all the panelists to spotlight once we start it, no? So you can see them all over there on the screen. Okay, Akshita, Jayashree, Anjali, you can just take up the back end part here. If you see anybody in the lobby, please admit them. Okay, so that we don't lose out in there.
Yes, ma'am.
Okay, ma'am.
Just Binu ma'am is a little bit struggling to connect in. We'll just waiting for ma'am to be there and we'll start it just in a couple of minutes. We already at 3:30. I'm just helping her to log in. 1 second.
हाँ 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 अभी मुझे फोन मत करना ज्वाइन कर लो तुम लोग भी
So very good afternoon, all of you. Please give me a thumbs up if it is audible in the chat box.
Yes, audible.
Great. So can I get some more thumbs up from the audience side? All right. So again, a very good afternoon to all of you. Welcome to Ivy Talks June edition. As we all know, it is hosted by the Delhi NCR chapter. And when I say Delhi NCR, it means Delhi chapter INS India. It means Haryana chapter INS India. And it also means the Noida and Greater Noida chapter INS India. So as you all know, this is the webinar portal of Microsoft Teams. Those who are attending Ivy Talks for a long time, they know this, but for the new audience, I'm Pooja Swaroop Saxena, Training and Scientific Education Lead, Polymed. And on this webinar portal, for the audience primarily, there is, you will not be audible and you will not be visible as well. So you will not be seeing the mic option on or the camera option on. So if you have any questions for the panelist, if you want to ask something, you can put in the chat box. If you want to speak up also, you can put in the chat box and that can be unmuted and your camera can also be on and you can be there and we all can hear you as well. Okay, so quickly we are just building up on the audience. We are 50 already. So can we quickly get from which cities are we joining in? Let us see where and all we have reached today. Quickly in the chat box, where and all we are joining from. We see a lot of people from Delhi, lot are from down south, yes. Oh, Bhubaneswar, nice. Great. So the topic this week, as you all know, INS Ivy Talks, every month on month, one chapter takes up the responsibility to host. This time it is 3 chapters combined. We have, as I already told, Delhi, Noida, Greater Noida, and Haryana. The topic that has been chosen for this month is very important when we talk and when we see from the, not only from the nursing perspective, from the entire hospital perspective, which is leading the way in infusion safety, nursing practices that matter. So today in the agenda, we have multiple things. We have a very, very, very interesting panel. So there is a panel discussion that we would be seeing. It would be followed by a very unique QIP description, QIP presentation, and followed by, as usual, the open forum. In the open forum, you can ask the questions to the panelist, to the persons who are there, to the INS Governing Council members would also be joining in. We'll also be having the General Council members from all across. So you can ask your questions, your doubts directly over there, and that would be discussed. All right. Also, we would be shortly joined by Binu ma'am, INS India CEO. So ma'am would be starting the officially starting the the flag off of the session. There is some technical glitch because of which she's not able to join in right now. So I guess shall ma'am, what do you suggest? Anu ma'am, shall we start it? Because ma'am is little bit held up, I think, with the technical problems.
I think we can just wait for 1 or 2 more minutes and then get going.
Right. That shall help. So, in the meantime, we may request the Delhi chapter chair. We have the chapter chairs here available right now on the call with us. So we may request the chapter chairs to start. The session. Binu ma'am will join in, and probably she will take it up from there. So we may start from Delhi. Then we have Lavleen ma'am. She's there, Delhi chapter chair. So Lavleen ma'am, you may start it. And then we'll be having Alekha ma'am is also there, and Minati ma'am is also there. So we can at least have a quick, welcome from the chapter heads.
Yeah, good afternoon, everyone, and welcome you all to this month's Ivy Talks, hosted by Delhi NCR chapter. And I'm sure the panelists are going to give you a worth of knowledge today in terms of infusion safety, medication safety, led by Dr. Anu Kaushik. And we have wonderful panelists. We welcome you all to today's session. Thank you.
Thank you so much, ma'am. Alekha ma'am, you may please, if possible, you can please switch on your mic as well. I think she's okay. Minati ma'am, are you there?
Yeah, I'm here.
Right. Thank you.
Good afternoon, all. Great, pleasant to be on the platform, all of you. So today the program will be in the three states, right? Delhi, Haryana, and Delhi, Haryana, as well as the Greater Noida. So all the panel discussion panelists, I welcome you on the board. I think it will give a immense knowledge, irrespective of our IV infusion safety. Welcome you board. Have a pleasant presentation. Thank you.
Thank you so much, ma'am, for your kind words. I guess in the interest of time, we can start, and when we ma'am joins in, we'll break in that time, ma'am. So, all right. So, on the behalf of the organizing team, let me welcome. We'll start with the panel discussion first, and let me welcome our moderator, Madam Anu Kaushik. I think all of us available here, ma'am needs no introduction to all of us, but still on a formal note, I will just introduce. Surbi, you may please help in sharing the slide as well. Can put it the next one. Surbi, you can change the slide. All right. So Anu ma'am is currently serving as a director of nursing with the Cloud9 group of hospitals. She's here with close to 30 years, close to 3 decades of experience in leadership and strategic planning. Ma'am has been the mentor for lots and lot of people, and we've been getting a lot of knowledge, lot of insights from ma'am on different forums. She's she's a quality person, and indeed she is someone who should be in the chair of the moderator today. So without wasting much of the time, I would like to invite ma'am. So to please take up from here. Thank you, ma'am.
Thank you, Pooja. Thank you, Laveen. Thank you, INS team, for having me here today. It's truly a pleasure to be part of this discussion. The topic that has been chosen, I think, is a very need-oriented topic, and I think is going to be of immense significance to all the practicing nurses. That is, leading the way in infusion therapy, nursing practice that matters. Before we go ahead and dive into the topic, I just quickly want to throw one question. It's not, you don't have to answer me, but it's something that we need to think. On an average, depending upon the kind of specialty you work in, a single nurse handles on a busy shift 10, 20, 30, 40. In fact, in some cases, I've seen 60 medications also, during that one shift. So that's the, I would say, huge amount of work that nurses do around medication management. And just imagine, out of those 40, 50, 60 medications that you've handled, only one of them goes into the patient's bloodstream. And that could either be in form of a wrong dose or a wrong rate, a wrong line. It could be anything. But the unfortunate part is there is no swallowing it back. Why I'm saying it is not no swallowing it back, because if it is an oral medication, at least you have an option to, kind of vomit out. But once it goes into the vein, there is no way you can pull it back, because the moment you push it, it already starts getting into action. So that is what is infusion therapy. The most routine thing we do, which we carry, but has the highest risk. So good evening, everyone, and a warm welcome to our panelists and our wonderful audience. We are here today to deliberate on the most pertinent theme, that is leading the way in infusion therapy, nursing practices that matter. I just quickly want to set the context, because this is an important topic, and I would want really all of us to focus on some of the numbers that really matter. And as nurses, we should understand the magnitude of this issue. You'll be surprised to know that according to WHO, that's World Health Organization, the global cost of medication error in US dollar is 42 billion. If I have to translate that amount of money into Indian rupees, is going to be 4 lakh crore. It's unbelievable. It's huge, and it's something that's irreplaceable also. And it is also being seen that out of every 20 patients, there is one patient who experiences this preventable medication error. And the problem with infusion is that when the medication is going into the vein, unfortunately, the margin for error also gets thinner. And that's the problem that we are going to discuss today. And I really love this theme, and I think it goes well with us, that patient safety is not one big act. It is 1,000 small correct actions repeated every single day. So as Florence Nightingale, I think we've all read this when we were nursing students, that the very first requirement in a hospital is that it should do sick no harm. Today, we ask how nursing practice makes that real one infusion at a time, which is absolutely safe for our customers. And without further ado, I would like to go ahead and introduce our esteemed panelist today. I think we have got Vinu ma'am on the call.
Yes.
Good evening, ma'am. So I think
Hello, good evening, Anu.
Yeah. So maybe I think we'll love to have your welcome note, ma'am, and then we'll proceed further.
Thank you, Dr. Anukashik. And apologies for joining a few minutes late. So we just heard from her what is the magnitude of medication errors or errors and what does it cost. And this we're talking of the United States. Imagine in our country where we do not pick up every single error, and even when we pick up, we do not report every single error out of apprehension, fear, ignorance, or delays. Infusion Nursing Society definitely wishes to drive infusion safety. And in infusion safety, the primus thing is safety of infusion for medications. We all understand it's a dynamically changing healthcare environment. Every single day, there are new drugs getting added. There are new innovations, new technologies, new disease burden. It's very difficult for nurses to learn about every single practice, but we do not have a choice. If we have to live up to the ethos of nursing, first do no harm, then it's imperative that all of you train yourself, get the SOPs in order, implement the right practice, and learn through the experts. I'm very, very glad to see today we have a unique collaboration of Delhi chapter, Haryana chapter, Noida chapter, people coming together from safety, quality, infection control, administration, our doctors, everyone involved, because safety is not one person's business. If one person in the chain breaks the norm of safety, patient is not going to get a safe infusion. With that, I welcome all the participants to today's 1.5 or 2 hours of expertise on infusion, right practice, the practice that matters. I also urge all of you to take it further to the mentees or the junior nurses you are working with. Thank you, everyone on the panel today. And thank you, Pooja, for having me here. And thank you, Anu, for showing up after a long time on the platform of Infusion Nursing Society. You are a very critical member, a general council member, and your opinion matters a lot.
Thank you so much. Thank you, ma'am. Thank you. Yeah, Pooja, let's have the panelist introduction. Huh?
Right, ma'am. So, Subi, can you please share the slides?
So we've got 5 panelists today in the panel discussion. We've got Dr. Farhan, Ms. Vidya, Ms. Kumkum, Ms. Priyanka, Ms. Pooja. Ms. Pooja is currently working as Deputy Nursing Superintendent at Sarvodaya Hospital, Faridabad. I think she comes with rich 13 years of experience in various areas of nursing practice, clinical, nursing administration, academics, and healthcare informatics. And she's currently overseeing nursing administration, academics, training and development, informatics initiatives. So a lot of things on your plate, Ms. Pooja. Happy to have you with us today. We got Dr. Farhan as one of our senior panelists. He's working as a senior consultant in hematology and bone marrow transplantation at Max Healthcare Saket. And we can look at the number of academic accolades he has to his credit. And he has over 10 years of experience in hematology, oncology, and bone marrow transplantation. And he's also worked in Kuwait and at Rajiv Gandhi Cancer Hospital, Sarvodaya, Metro, and Max at presently. And we've also seen that he's done a couple of presentations. Welcome, Dr. Farhan. We've got Ms. Kumkum Ghosh. She's having more than 30 years of experience in clinical as well as academics domain, and she's handled different profiles in eminent hospitals. And she's currently working as GM nursing and paramedic education, and she's associated with a lot of prestigious organizations. We've got Miss Vidya Siji. She's an infection control nurse at Fortis Hospital in Noida, and she's done post-basic nursing. And she comes with 7 years of experience in Fortis Noida. Welcome, Miss Vidya. Next, we have Miss Priyanka Kumari. She's done her bachelor's in nursing and an MBA in human resource and digital marketing. She, is a member of Oncology Nursing Society, and she comes with rich 10 years of experience in clinical oncology and BMT transplants. Welcome, Priyanka. Miss Hemanti Chaudhary is going to be one of our QIP presenter after the panel discussion, but we will like to introduce her now. So she is having 5 years experience in clinical nursing, healthcare quality management, and patient safety. Quite a budding nursing professional, I would say. And what I hear from Ms. Pooja is that she's coming up with a very interesting QIP presentation, and we are all eagerly looking forward to hear it from you, Ms. Hemanti. Thank you. Right. Let's begin.
Ma'am, you're muted.
I'm so sorry. Yeah. I'm saying let's begin. And let's start with, one of the highest stakes corners in the hospital, that is hematology. And we've got the right person also. So when we talk about hematology, there are a lot of things that, run or cross our mind, that is chemotherapy, blood products, anticoagulants, immunosuppressant, etc., etc. These drugs, the peculiar thing about them is that where, a small error in these kind of drugs doesn't stay small. So that means the repercussions are huge and consequences are very severe. So they demand precision, vigilance, and a team that communicates. So I would like to request Dr. Farhan to help us understand more so that we are able to, kind of take away some important messages, in terms of our clinical practice. And I have 2 questions for you. One is, and I'm asking these 2 questions together because they are interrelated. One is, in hematology care, which medications or infusion should nurses treat as high risk and why? And what are the most important safety checks before starting chemotherapy or blood products or any other infusions the nurses need to be, careful about? Over to you, Dr. Falan.
Dr. Anu, I just take your first question, that what are the medications which are at high risk. So truly speaking, any high dose chemotherapy, I will say it's a high risk for us, especially the drugs which are vesicant. And the most the drug which really we are worried of are the drugs, anthracycline group of drugs, like adriamycin, doxorubicin. So doxorubicin. So these are the type of vesicants which commonly cause loss of tissue destruction and necrosis. So these are the few drugs I will say, especially these 2 drugs. Plus there are some drugs called vinca alkaloids like vinblastine, vincristine. So these although they are small, just IV push medications most of the time, but still any small excavation can have a big impact because a lot of tissue damage at the local site and necrosis damage. And the second is regarding to the second question. So special precautions for something someone has to take. So this is a high dose methotrexate. The high dose methotrexate is something where the time of starting the drug and the end of the drug, it should finish on time. Even a delay of suppose the 2-hour infusion finishes in 2.5 hours can have a big impact. So toxicities, because most of the time it is given for just for the CNS, and high doses are given to reach the central nervous system and avoid the systemic exposure by removing the drug as fast as possible from the body. So if it is given, even for a slightly more duration of time, that can have a big impact. So, but still in the hematology, or not only hematology, in the oncology also, any high dose chemotherapeutic drug can impact it. And the other drug, especially for BMT, I can see there are many staffs which are working the senior staffs which are working the PMT. So the one drug which is called melphalan, they should be extra cautious because it's a very short half-life, and it should be mixed and infused as fast as possible without having any delay, because any delay will affect the efficacy of this drug. So this is how there are certain drugs which are especially important. And if you allow me, I can share a few slides from my side.
Sure.
So my slide is visible.
Yeah, it's visible. If you can put it in a slideshow, yeah.
Okay. So just I will have a small presentation on the high-risk medication of immunology, safety consideration, infusion, and the multidisciplinary approach to the medication, infusion safety in immunology care. So what the points which So what I want to discuss is the first the safety standards as per the. So what we I think what most commonly we follow is the ESCO guidelines, American Society of Clinical Oncology, and I discuss on the clinical verification, what are the requirements before giving a chemotherapy, any adverse event when it happens, how to manage it. As I know that only 8 minutes are allotted, so I would be little fast. Many of the slides. I'll start with the creating a safe environment. So it's very important because these medications, as you told me, when once it goes into the intravenous and it's a wrong dosing or anything which is wrong, it cannot be reverted back. And if it happens, the chemotherapy will have a big impact to the patient. The institutional policies must enforce routine initial competency certification and mandatory annual ongoing training for all staff. That there should be robust policies must strictly regulate drug transport, centralized compounding like laminar safety goods, and the emergency hazard plan ability. This gives a more confidence to the nurses who are going to administer it. If they are having a regular training ongoing, they have a safety uh, policies for safety plans and how to manage the and hazard. All the plans, it's their ongoing. This give a more confidence to everyone. Second is when the treatment and care planning. So every oncology regimen must define the patient's diagnostic stage, clinical intent, and the documented consent. So this paperwork is very important. We should be document what is patient's name, patient's height, weight, body surface area, diagnosis, what is the intent of the treatment, and not only this, the standardized templates for orders are mandatory. Like if we are ordering a chemotherapy regimen, if there should be a standardized templates, not that we write anything in a bit of paper and give to the nurses that please use the chemotherapy. No, there should be a standardized template for giving the chemotherapy that should be properly filled, and it should be ensured before giving chemotherapy by every staff. Coming to the pre-administration checklist, very important when you are administering a chemotherapy. So it's not the antibiotic like routinely we give a fluids, antibiotic, supportive medication, but when we are giving a chemotherapy, we should ensure that there is a consenting signed by the patient. So this should be cross-checked, and this should be the reflexes of the nurses who are going to give the chemotherapy. So consent should always be there. We should check that whether patient's routine evaluation has been done in the form of routinely the organ function as the CBC, KFT, and the viral markers. And next is we should confirm the height, weight, body surface area has been taken with the current cycle, not taken 1 month back. It should be every time should be taken. Third is the dose recalculation. Always we should do before giving the, as we have all have the standardized these formulas. We have the apps in the phones everywhere. We can have even our softwares which we are using, CPRS, they have this the body surface area calculators. Next is the bedside clinical verification. Whenever a patient we are going to administer the chemotherapy, patient identity should be identified. You confirm it 2 times, but it should be it's very important. Check the dose, route, name of the patient, what the drug to be administered. Everything is very clear or not. And next comes the personal protective equipment. So what is few things which are very important, which I would really say enforce it. Someone who is good at handling the chemotherapies, use the double gloves. There should be impermeable gowns, face shield if available. It's good because it avoids the eye splashes. And the respiratory care will utilize usually N95 masks are available, so it should be utilized by the staff nurses who are giving the chemotherapy. Next is the venous access. So make sure the venous access is proper or not. So first is the central venous access. So the chemotherapies, which are multi-drug chemotherapies, infusional chemotherapies, these should, or something is a highly concentrated vesicant drugs. They should always be administered through the central venous lines, and they should be flushed thoroughly with the saline. We should check it that the flow is okay, it's going well, there is no swelling, no pain. Everything should be checked once we are giving the central using the central line. Again, peripheral venous access, if we are having only short-term chemotherapy, we can avoid this, but it should be a fresh cannula, always a fresh peripheral venous access, especially for a vesicant drug. So never administer a vesicant infusion through peripheral line for 30 to 60 minutes, and it should be placed a new one. It should avoid the joints, fragile veins, and this is a very basic, but yes, it's very important when, especially when we are giving a vincristine. I have seen using a cannula being placed a day prior and being pushed, and it leaked and caused acceleration. So this should be it should be a dictum. If you are giving, it should be a fresh peripheral venous access, otherwise central line should be there. And then infusion vigilance, like we should, I think skip this, is not that important, more important. So now coming to drugs, which are more, how you classify drugs when we give and where we should take the more precautions. The first and the most important, the vesicants. So vesicants, they cause severe tissue destruction, necrosis, and make the blisters. So these, we should be extra cautious for these. So like doxorubicin, vincristine, vinplastine, mitomycin, these are the vesicants which are especially we should be very cautious when giving this. Exfoliants, they can cause superficial skin swathing and blistering. So it's like cisplatin, paclitaxel, docetaxel, and we have other the irritants and the neutrals. Next, emergency extravasation pathways. So most important, and I used to ask everywhere when I go to daycare, I keep asking every staff that what is your, how will you manage if you suspect the extravasation. So I think everyone should know these things, because even a small steps can prevent big injuries to the because of the extravasation. So first and most important is the halt, stop the infusion. Second is never remove the cannula immediately. You halt it, but don't remove the cannula immediately. Aspirate. Try to aspirate as much as the residual drug possible. Then you have to treat it. You have to remove the cannula, and what you have to do, you have to provide either a warm or the cold disposables. So how to compression, cold or warm? It depends on the type of drug being administered. Like certain vesicants like adriamycin, doxorubicin. We should use a cold compresses here. Why we should use a cold? We avoid further blood circulation and the dispersal of the drug. Again, if you the Elvis vinca alkalites, it should be a warm compression. Not only this, there are certain antidotes available. I think we don't have it currently available, but at least we should be knowing this, how to manage the extravasation. And as soon as once patients improves, it should be referred to the plastic surgeon or a surgeon, if whatever available in your place, to just monitor this area of redness that should be marked with the pen, and keep watching about the change in the skin color or something. I think it's always good to refer, if you are documented that this is extravasation, the plastic surgeon should always see this. I think this is all I want to speak about.
Thank you so much, Dr. Farhan. I think it was very, very insightful, and I really really liked the emergency excavation, pathway. I think this is going to be very handy document and will also help nurses to, address if they are, stuck in a situation like this. I think your message is very clear. In hematology, safety is never a solo act, and it's a system, a conversation, and a nurse watching closely at the bedside. I think that's the takeaway. Thank you so much, Dr. Farhan, for your valuable inputs. We move on to Miss Vidya, who's going to be, talking in detail about infusion-related infections. And I think when we talk about this topic, the first thing that comes to our mind is clepsy, right? And clepsy is known to, cause whooping 28,000 deaths a year. This is according to the US statistics. And as Binu ma'am said, we don't have, an accurate data for the Indian setting. But what is more also surprising is that, almost 19,000 crores rupees are being spent, on this infection. And it is also the highest mortality associated, and it goes up to 12 to 25%. So, in terms of, severity, the incidence and the cost are humongous when we talk about infusion related infections. So now I would request Ms. Vedya to help us understand what are the most important nursing practices to prevent infusion related infections, and where do you see the most important gaps in nursing practice? Is it during cannulation, or is it the line access, medication administration? Would love to hear from you.
Ma'am, you are on mute, ma'am.
So very good afternoon, ma'am. Ma'am, am I audible?
Yes, now you're audible.
So, ma'am, as per the question, ma'am, the most gap we found, the first thing is the hand hygiene. Second thing, we found gaps whenever the medications they are preparing. That time also we can found the gaps in that. Hello?
Yeah, Miss Vidya, we can hear you. Yeah, please go ahead.
Ma'am, am I audible?
Yes, you are.
Yes, ma'am.
Would you like to run us through the presentation?
Yes, ma'am.
Please go ahead. Yeah.
So, shall I start the presentation now?
Yes, please.
So today we are starting. Today I'm presenting the topic on preventing infusion-related infections to the standardized practices. So as we all know, infusion therapy is one of the most frequently performed procedure in hospitalized patients. It is used for IV fluid, medications, blood products, electrolytes, and parenteral nutrition. The type of VAD we are using for the patient is peripheral IV cannula, central venous catheter, PICC-line, midline catheter, and implanted ports. So where we get the infusions related infection from, where it is occurred. It can occur when the microorganisms enter the bone through an intravenous line, catheter, or infusion. So these can affect the patient local site infections like phlebitis or cellulitis the patient can get, and of course they can get the catheter related bloodstream infection, CRBSA. The commonest microorganisms which we are seeing in the patients are Staphylococcus aureus, Corns, Klebsiella, and Pseudomonas. So how do we get the infections through the IV site or cannula? So the commonest way of infections are because of poor hand hygiene. Second one, the improper skin preparations. And the third one, the contaminated devices we are using for the patient. The failure to disinfect the IV port and hub. And the fifth one is the contaminated IV fluids or medications or equipments we are using. The sixth one is loose, wet or soil dressings. And the seventh one is repeated unnecessary lines. The patient is having multiple lumens of lines. And the eighth one is prolonged retention of IV lines. So next we will move to how these germs enter into the IV system. So it can from the skin, or it can from the contaminated hands of the healthcare workers, or from the IV hub or ports, or from the contaminated fluids or devices we are using for the patient, and from the environment itself. So what are the possible outcomes for this? The patient can develop the local site infections like redness, pain, swelling, discharge, and discharge at IV site. Phlebitis, catheter colonization of and patient can lead to CRBSA, catheter-related bloodstream infection, and patients went into sepsis. So these are the signs and symptoms of infusions-related infections. The patient may develop redness and swelling, warmth and tenderness, pain or burning, pus or discharges, fever or chills, and phlebitis. So what are the key standardized practice for prevent these infections? First and most important thing is hand hygiene. The 5 moments of hand hygiene we should follow whenever we are handling the patient, especially performing any procedures. Second one, proper skin preparations with antiseptic solutions or allowed to dry to complete before the insertion. Third one, using the aseptic non-touch technique whenever they are performing any procedures. Maintaining the aseptic technique during insertion and medication administration. Do not touch the key part of the cannula, especially cannula, syringes, or ports. Disinfectant hub, IV hub port before every access, especially scrub the hub for the recommended timing and allow to dry before accessing the line. Use clean and dry intact dressings and ensure the dressing when it is clean and dry and well secured and change if wet or loose or soiled. The sixth one is daily we have to assess the IV site assessment. Assess the IV site every shift and before each infusion. Check the IV site for any redness, swelling, pain, leakage, and patency. And we have to flush the line properly and maintain a closed system always. Do not disconnect the catheters unnecessarily. And timely, you have to remove the lines and safe medication administration as you have to verify the medication and patient, use sterile equipment and follow correct dilution and compatibility and infusion rates, and accurate documentation is also necessary. So the last one is the most important thing is nurses' role in preventing infusion-related infections are the following: hand hygiene aseptic technique whenever they are performing any procedures, performing correct IV insertion and line handling whenever they are performing any procedure like IV cannulation or whenever they are handling the central lines or peripheral lines or PIC lines, assessing IV site regularly, identify the complications early as already we discussed, educating the patient to report pain and swelling or redness, and we have to check the patient's IV site, maintaining accurate documentation and escalating the concerns promptly, and ensuring line removal when not needed. Thank you.
Thank you, Ms. Vidya. I think it was very, very insightful. You covered a lot of practical aspects, and I think the young nurses will immensely benefit from this discussion. And your message is very clear. That is, infection prevention is not an event. It's every touch, every connection, every flush, and every dressing. Thank you, Ms. Vidya. Now, let's move on to the next, topic, which is, personally very dear to me. That is, creating a culture of safety. When we talk about, safety, there are a lot of things that, crosses our mind. But here is an uncomfortable truth. Safe infusion therapy cannot run on memory and good intentions alone. It needs culture. It needs leaders who make it safe to speak, safe to report a near miss, safe to say, I'm not sure before the drug goes in. So there is a principle in patient safety, and I want us to hear it, and think about it. That is, a good nurse will lose to a bad system every time. So if we don't fix people, we need to fix systems, I think. So whenever we look at an error, I think it should not be seen as an individual error. It should be seen as a system failure, because we need to think, why did this error happen? What was not right in our system that the nurse could, manage through, the loopholes, and, this error happened. So let's shift from blame to learning, from silence to speaking up and reacting to preventing them. So I have a few questions for Ms. Kumkum. I would like you to talk about or run us through, what does a strong safety culture look like at the hospital level day to day? And how can leaders get nurses to report errors and near misses without fear? And how do you protect, you know, uh, the safe practices when you are undergoing challenges like, your unit is extremely busy, you are short staffed and under tremendous pressure? Because this is something that we experience day in and day out. So over to you, Ms. Kumkum.
Good afternoon, everyone. So your questions in day-to-day life, how we can just stop, we can have a good culture and all. One thing I feel from personally, I feel it is a teamwork. Second is culture. It does not grow within single day. It needs the consistency. It needs the leadership vision, and as well as is also needs the supervision day-to-day life. Because until unless we supervise the things whatever is already going on, we cannot just think that it is already done correctly, how I have already shared, or how I taught them, what is the training I have already shared with them. Until unless clinical, so it cannot happen if sitting at your office with AC proof office and you are not going to the patient bedside and you are seeing clinically what is actually happening with the patients. So leadership is very important, culture is very important, consistency is very important, with everyone's support and with a just culture. That is what is the gist out of it. Shall I share my screen?
Yes, please. Yeah.
Okay.
I think some technical glitches there. It's got hanged over there.
Is it visible?
Yeah, ma'am. Now it
Is
is
it?
visible. Mhm.
Can you can you see the slide?
Yes,
Yes,
now we
ma'am.
can.
It is
Now
visible.
we can,
Yes,
yeah.
ma'am.
There is some delay in this. Okay. So as Dr. Anu has already discussed, that systemic reduction of the 50% of medication error, that is the call of WHO, and with the cost of medication error is already $52 billion as per the US dollar. Okay, so here it requires the intentional approach from the healthcare leadership to standardize the clinical safeguards. What's happening? Second is, if we see that how much types of errors are already happening, there is the administration error 20.83%. You can see there are dispensing error, there are monitoring error, there are errors which is already happening with the ordering and prescribing as well as the transcribing. So this is the overall data, how the medication errors are already happening. So in that aspect itself, so it is from the prescribing, from the transcribing, dispensing, and administration, everything is already happening. Now, if you see the data itself, you can see that there are very big data which is already related to the monitoring and the reporting. So this monitoring and reporting, this particular data, we can improve with our culture, mainly the data which we are getting everyday basis. Maybe there is one error is already happened or near miss, all these things. But if something already had happened after giving the medication, even during the monitoring, if it would have been already stopped the fatal effect, timely monitoring had done. So that is again a very big data, that is 35.556%. And ordering and prescribing, that is even in the scenario itself, ordering and prescribe, again you will see, if suppose a tablet of thyronam which is actually prescribed 0.1 milligram, a nurse which is seeing that particular medication, it is 100 microgram. Even the nurse might not be knowing that 100 microgram is equal to 0.1 milligram. So that is again one important aspect. Whenever the doctors are prescribing, if the data of that particular unit is not correct, sometimes it is also confusing for the nurses. So we have to also look into that point of view, how we can improve that. Now we have to analyze the high risk landscape. So poor standardization, nomenclature of the medication, which all are the, suppose there is a list already provided from the pharmacy. These are the look-alike, sound-alike drugs. But whatever you are using at your unit, you have to see in my unit, these are the things what I am using. And out of that, these are the look-alike, these are the sound-alike. So we have to actually improve our nomenclature. We also have to guide our junior staff to speak up for that. We also have to see they are working double duty, they are working for long hours, so they are already mentally fatigued. So how we can improve that particular aspect, how we can take care of that, how we can ensure that this particular nurse may prone to have this particular errors and all, how we can improve that. Then the point of care risk. So the lack of understanding medication, flow rate, how we can adjust. Route, what is the exact routes? Sometimes there is a one medication which is already very rarely once in a full moon is already used for a patient of the idiopathic thrombocytic purpura. Doctor has written this particular drug you have to give subcutaneously. There is a 10 ml of solution is already available, but it is written in the microgram. So as administrator, they must have that faith on you that they can ask you and try to get the how to dissolve, how to give. So your approach should be very positive towards them. We cannot just say, oh, you do not know. This will not work. You have to be careful. Then sometimes the patient control analgesias are there. Again, we have to be very, very careful about that. Then the compounding vulnerabilities, critical workflow depending on the high risk error prone manual compounding operations. So at our hospital, what we have developed, suppose a person is getting even IV infusion, we have made even from the 10 ml to 500 ml, sorry. So 10 ml to 500 ml, how many, if you are giving IV set, how many drops? If you are giving micro drip set, how many drops? So it's a ready reckoner for them. They will not have any query, or they can just ready reckoner, they can just take it. Even for the same thing we have already developed, if they have to give the syringe pump, so how many ml, if it is 1 hour, 45 minutes, 30 minutes, how many ml per hour they have to actually adjust. It is a very, very ready reckoner, and they can actually just check this and they can follow the same guidelines. sometimes this type of drug, suppose the patient has to give cortisone injection, doctor has already asked, okay, you just dissolve 300 milligram and you have to over 30 minutes or 20 minutes, or 150 mg bolus, you have to give within 20 minutes. So this is the ready reckoner what we have already developed for our nurses. And we are believing on the just culture, not no blaming culture. So we all the senior person, every day, every patient, we try to meet each and every day executive work rounds and continuous feedback from the patient on from the ground level. So clinical domain, we have to think about the IV push high alert drugs. We have to see the PCA therapies. We have to see the safety incidents. Then the legacy of the practice culture, individual manual, even the nurses, mathematical calculus, they are not very confident. We have to take care of it. We have to see if the PCA therapy is then infrequent, delayed, visual, physical check-ins, what are all these things. Then safety incident, punitive warning individuals, we are not believing on that. We have to be very, very positively, we have to think about that. High reliability leadership safety design, we have to see that we have to use the technologies, okay? And we have to see how we can use the premix syringes and all. Then the PCA therapy is again continuous capnometry taking, integrated respiratory alarms we have to see. So it's a multidisciplinary, we have to see mode and effect the systemic analysis. So safe technology, mandate the standard and drug concentration, unified dosing parameters, smart and infusion pumps, we are already procuring. Then the patient control analgesias, barcode medication administration, still not, we do not have, but we are into it because we are going to, this hospital is not that tech friendly, but we are obviously within another 3 months, we are going to procure all these things so that our patient will be in the safer hands. So this is our 12-month implementation roadmap. First, 1 to 3 months, diagnostic safety culture survey execution. So we have to see what all things new ready reckoner we can just create for them. Then we have to all the operational workshops and clinical standard alignment criteria we are setting. Then the system-wise deployment of the locked drug profiles and active bedside barcode verification validation, that is also we are going to start. And baseline CQI and the POI, all this aspect, we have to take it forward, and like that itself we have to continue our work culture. So this is what we actually continue everywhere. If you see this one, there's the OT, ICUs, even the students are coming. We are already giving their positive feedbacks. Our MS, they are also involved with that. Even the ICU personnel, we are conducting our workshops. So this is, again, I am repeating the same thing. First, do no harm. So we have to actually focus on the first, do no harm. Thank you.
Thank you, Ms. Kumkum. I think it was great to see, some of the wonderful safety culture initiatives that you are, you've launched in your hospital. While you said that, you are not very tech savvy, but I see, some of the very wonderful, initiatives that you have, taken. And I really like this IV fluid and syringe pump administration guide, which is, I think, a wonderful tool for nurses to refer. So pretty happy to see, some of the good initiatives, and I'm sure people who are hearing would, like to implement the same in their hospitals as well. And as you rightly said that, its safety is built in small daily acts of how we guide, how we audit, and how we appreciate and support each other. And I think most importantly is how we, encourage a culture of self-reporting, which is, non-punitive. Thank you very much, Ms. Kumkum. Thank you. Now let's move on to the next important theme, which is associated with our panel discussion today. That is the safety checks and vascular access journey. We are all aware that Infusion Nursing, Society has launched the standards of practice, which exist, or which help us to ensure that we have good practices which are consistent and which are being followed very diligently. and they're not optional. I think that's the very important takeaway. So remember that starting an IV line is the beginning and not the finish line. So I would request Ms. Priyanka to help us understand what are the key medication safety checkpoints before starting any infusion, and during an infusion, what should a nurse, be actually watching for, and and is she, uh, capable of picking up the early warning signs, and after completion, what are the important documentation and assessments that she needs to adhere to? So, Ms. Priyanka, over to you now.
Thank you, ma'am. Thank you for having me. So, mainly I work in oncology department, the medical oncology and hematology. So, I mainly be focusing on chemotherapy infusions and administration process and safety checklist and extravasation management for all those things. So, I'll just share my screen. Just so first we need to understand what are the chemotherapy drugs. Am I audible?
Yes, you are audible, Priyanka. Yeah.
Yeah. So, what are the chemotherapy drugs? The chemotherapy drugs, medications are used to treat cancer by killing or stopping the growth cells of fast dividing cells. So, there are different types of chemotherapy agents, alkylating agents, antimetabolites, anti-tumor antibiotics, and plant alkaloids. And like Dr. Farhan already mentioned all those things, I guess. So, there are a lot of topics which he has covered already. So, there are some chemotherapy administration safety core principles. So before pre-administration, from the nursing perspective, there are many checklists we have to go through. First is independent double check of the medications, the drug name, dose, concentration, route, what rate, and infusion, double ID checks, and the body surface area calculation, and any allergies of the patient. Verify the chemotherapy protocols, what cycle it is, what chemo pre-medications are mentioned, the hydration, the lab values, which are in the safe limits, and the obviously the consent from the chemotherapy, which has to be signed prior starting the pre-medications and the whole process for chemotherapy. And the next one is choosing the right vascular access device. So generally we prefer central lines for the vesicants and anthracyclines, and we avoid peripheral lines for the irritants, which can lead to extravasation in any case and any time. And assess the excess blood return presence or no swelling, no resistance, no infiltration prior starting the infusions. So second one is safe preparation and handling of chemotherapy. So all the nurses in chemotherapy areas like chemo daycare and the whatever areas they're handling the chemotherapy, they are supposed to wear the personal protection equipments like gloves, gown, eye protection, respirators if aerosol risk is there, which is always there. And we use closed system drug transfer devices like Lure Lock and Clave Nectars and all those things. And labeling of the medication, the right name, right drug, right dose, dilution, expiry medications, and hazardous drug labels are always there. Like cytotoxic drug labeling is always there on the bags of chemotherapy. The safe environment for the preparation, there's a different cabinet, biosafety cabinet with HEPA filter is there to prepare the medications. And during administration, we generally, for the first time especially, stay with the patient for the first 5-10 minutes just to check the vesicant infusions and all infusion. Patient can develop allergic reaction and anaphylactic reactions to the medications, and monitor patient continuously, ask about the pain, burning, tingling sensation, and inspect the site for 5-10 minutes. And if there's anything problem patient is mentioning like a resistance or anything, then we should stop the infusion immediately. In case of pain, swelling, resistance, lack of blood return, patient systemic symptoms like rashes, shortness of breath, hypotension, which can be because of anaphylactic reaction. And one vesicant at a time per lumen. So there's no IV push medication, and only few medications are allowed for the IV push. And before that, we are supposed to check the backflows and the patency of the IV cannulas and central lines. And we should use infusion pumps with anti-free flow and air inline alarms. If there's any any occlusion, it should alarm. And for the extravasation readiness, there will always we have to be prepared in case of chemotherapy infusions to prepare for the, any sort of extravasation. First, we have to know the class of a drug. So these medications are divided into vesicants, irritants, and non-vesicants. Like Dr. Farhan already mentioned, vesicants are the more dangerous one. Irritants are like they cause some sort of phlebitis, and non-vesicants are not that much dangerous, but still they are. So there are different antidotes for all the chemotherapy medications, and we have to prepare the thermal compressions for hot and cold for the bedsides if there's a high risk medications. And documentation is a very important before and after the transfusions. If any sort of extravasation happens, so we are supposed to know what sort of medication has caused that reaction and how to manage that class of drug of reaction. So we follow this SLAP protocol. First is S stands for stop infusion, leave cannula in place, aspirate the residual drug, and plan antidote and the thermal therapy accordingly, and inform the treating consultant immediately. And post administration, flush the lines, the cannulas or peripheral lines or the central lines with saline, heparin policies for the central lines, and flush with a positive pressure lock so that there's no backflows, and we have to prevent the lines also. Patient education, report pain, swelling up to 72 hours later. Skin care, we have to educate our patients to report all those things if they have anything peripherally. And documentation of right drug, dose, site, patient response, educations are given. If phlebitis occurs later, our documentation can prove that if line was intact during infusion, and this we can save ourselves in that matter. And safe disposal of chemotherapy waste in cytotoxic bins, no recapping needles to avoid the pricking and needle sticks injuries. And as an oncology nurse, they plays different sort of roles in chemotherapy areas. They are safety leaders, be the last checkpoints, and they can prevent and correct the errors. And they are coordinator bridges between the consultants, the pharmacy, the patients, and everywhere. And they are educators and empower the patient self-reporting of the symptoms. So vascular access management, there are different sort of central vascular access devices which are used for long-term therapies, TPNs, parenteral nutrition, poor venous access, irritant medications, frequent blood draws, and blood transfusions, which are common in hematology and medical oncology. And to have the assessment of all those devices priorly the chemotherapy, just to prevent the infiltration prevention. If there's the medicine infiltrates in the tissue, we have to have those assess it priorly and select a right vascular access device. And same for the extravasation prevention and the phlebitis prevention, occlusion and dislodgement of the catheters. And at the end, I would say chemotherapy safety is 3 rights and 3 times: right drug, right patient, right route, before, during, and after the chemotherapy. So overall, the agenda of chemotherapy safety is we have to be very careful with all the lines and how we access the lines, and the right dose, route, and the checklist for all chemotherapy. Thank you.
I think, Priyanka, I don't know how you managed to, cover up such a vast topic in, such a short span of time, but very well covered. And you've touched base on, the most important checkpoints for the nurses. I really liked your SLAP protocol and your concluding slide, that is 3 rights, 3 times, which is, I'm sure will be used by many of our nurses. Thank you so much, Priyanka, for taking us through this. Thank you.
Thank you, ma'am. Thank you for having me.
And our final pillar, and I would say probably the most important one, that is competency, because a policy on shelf saves no one. But a good protocol only becomes safety when a trained nurse who's confident carries out properly the way it's supposed to be. So competency is, in my opinion, is knowledge plus skills, plus judgment, plus confidence, which is being reinforced again and again. So may I request Ms. Pooja to help us, dive into this particular theme and help us to understand a couple of questions on this theme. That is, according to you, what are the core competencies should every nurse must have before, taking the task independently? And how can hospitals train effectively on high alert drugs, pumps, vascular access, and infection prevention? And what are the different strategies you think? Do you think is the skill stations, or is it the demonstrations, or it's a combination of simulation? Because you've been working around it, and we would love to hear. Because and we also see that we have a lot of young nurses coming into the hospital. So this is something we are very eager to hear from you. Over to you, Miss Pooja.
Thank you so much, ma'am. So, talking about the competency, if we say that this is actually the capability to take care of the patient in a way so that a privilege can be given to the nurse to take care of the patient. So today we are talking about the medication safety and infusion safety. So competency will be related to the infusion and the medication administration. So I'll just take you to my slides and we'll discuss about the same. My slides are visible?
Yes, yes. Put them on a slideshow, please, Pooja.
Yeah. Yeah. Thank you so much. So first and foremost, I would like to just talk about it. Like we are talking about the competency, but why we need to have the competency? Why we are talking on medication safety? Why we are talking on infusion safety? So there are some reasons which have been given by WHO as per the survey in 2026 January, that 3 millions, more than 3 millions of deaths are occurring annually because of the medication errors. And if we talk about 100 medication errors, out of those 100 medication errors are IV infusion related errors, 54%. Then hospital admissions, 5.2% are of them because of the adverse drug events. And that one adverse drug event is having 2.5 lakh cost. So per drug event, it is approximately 2.5 lakh, and it is a huge amount which we are actually spending on high cost and because of all these medication errors, and which is preventable. So today we are going to talk on that. My main objective would be like staff would be able to understand the importance and updation, how to store the medication safely, and we'll talk about the prescription clarification. So doctors are prescribing, but we should also speak up for the clarification, dispensing check, and the administration and monitoring of the medication, which is a part of our NAPH chapter, management of medication. Then competent care, which has to be given to the patient who are receiving the infusion therapy. So this is under the care of patient chapter of NABH. Then we'll talk on 5 basic rights of medication administration, 3 basic checks, which will lead to the zero deviation of medication administration and zero harm. Then we'll talk on the importance of high alert medication administration and what is the importance of the correct calculation of the medication, like use of double check, which we also say 4 eyes principle. So these are some data which are given by WHO, and the main root cause, if we can see, it is wrong dose. So calculation, if it is not correct, and specifically if we talk about the pediatric dose calculation and little errors in the decimal, like 1 ml, 0.1 ml becomes 1 ml. So it will be a big error and it can lead to a fatal and cardiac overload and damage to the patient. Then followed by wrong rate. So suppose the staff has already knowledge of drug and dose calculation, they are calculating it properly. But if they are not competent enough to set an infusion pump correctly, to put the rate correctly, it will lead to a major mistakes. So 23% of medication errors are because of wrong rates, which is followed by wrong drug, and then omission because of the workload, as our earlier speakers also mentioned. Then the identification of the patient was the reason for the medication errors. With that, we talked on medication safety. Infusion safety is also we need to. So Anu ma'am also said that numbers matters. So number actually matters, and we have a 10 times of overdose risk if we are not able to set the infusion pump correctly, the rate correctly, and suppose if any infusion has to be go within 1 hour and it is going within 10 minutes, it will related to a great cardiac overload and hypovolemic shock. Then pediatric calculation also, which is a very vulnerable and at risk of medication error. So a simple point micro dose of the medication can also be fatal to the life of the neonate. Then extravasation risk. So Dr. Farhan and Ms. Priyanka has already discussed on this part. So if the sites are not being properly checked and the staff is not competent enough to know about the emergency extravasation pathway or SLAP protocol, which was mentioned by Priyanka, then the patient is going to be like in a chaos because it will lead to a tissue necrosis. So safe practices, we need to follow correct dose, rate, and volume has to be triple checked before starting any infusion pump. So basic framework which we should follow is follow 5 rights of medication administration, that is correct patient, correct drug, correct dose, route, and correct time. 3 check safety bundles are like if we have taken out the medication from our inventory, we need to check that time. Second check will be while we are preparing the medication, that point. And third check is while we are reaching to the patient and we are there to administer the medication that time. If we are doing these 3 checks with the 5 rights, 5 medication rights, surely we'll be able to achieve the correct medication administration to the patient. And as per the study by CDC, after implementing of 3 check protocols hospital-wide, the wrong patient errors dropped from 8% to 1.2% within 6 months. So this research evidence is correctly saying the importance of these 5 rights and 3 checks safety bundles. So this framework, we need to take it as a training strategy in our nursing induction and our continuing nursing education programs as well. After that, the main focus on high alert medications, like how we need to handle it. So for that, we have specifically all the hospital, those are accredited, they are following the independent double check 4 eyes principle, like one another person, senior person, he or she is checking the medicine, calculating the dosage side by side, both are calculating, and if the answer is same, accordingly, that dose has to be administered. And in case of high alert medication, that has to be labeled with red. Red means risk. So that the separate storage can be done for the high alert medications, and same with the look-alike and sound-alike medications. Especially we can see high alert medications, anticoagulants, insulin. So we need to look at the vial exactly, like what units are written. Is it 5,000 or 25,000 units per ml? Whether the insulin syringe is U100 or U40, because these things can cause a major hypoglycemia in the patient. Then knowledge about the concentrated electrolytes, whether they have to be given with dilution, whether they have to be set in an infusion pump with a proper ml per hour, and it should not be directly pushed to the vein. Then inotropes and chemotherapies also has to be given, and in between, we need to check the site. And if it is not checked, it can lead to tissue necrosis. So these all are the safety check alerts which we need to see on high alert medication. Drug calculation and identification of look-alike and sound-alike drugs. It is a very important part of the knowledge aspect of the staff when we are teaching the staff during our trainings. So we need to tell them about the Tallman protocol. So starting words has to be capital so that they can make out the difference about the medications. Staff should be knowledgeable enough about the actions and what are the neutralizer agents of these drugs if they have given in excess, when they need to report, when they need to inform to the doctor, and how to cross check the drug calculation also. So sometimes doctors are prescribing and sometimes they are making an error, like decimal error. They are writing 0.4 mg, they are writing 0.4 mg. So they have forgot to mention the dot, or the dot has been missed. So we should be knowledgeable enough to identify that and to speak up for the clarification to the consultant. So competency assessment, it is a journey which is getting started from the new when the staff is joining, and it ends because learning never get ends, and the technology is also getting risen up. So during the induction only, when the new staffs are joining, we are conducting a pre-test for them, and after the pre-test we are doing a zero frequency competency assessment, and then after that we are getting what the level of knowledge they are having. So accordingly we are giving them trainings, and to enhance their skills we can have OSCE based stations, that is objective structured clinical evaluation. So on the basis of a checklist and parameters, we can have some stations on which we can program various types of drug dose calculation stations, then high alert medication double check activities we can plan. So these can be done. And after getting successful completion of OSCE by the staff nurses, that we can do one more point addition, that is visiting to the bedside, observing them and having a bedside audit. At least 4 to 5 observations we can make out while they were giving medication to the patient and in front of the preceptor. Like 1 month of joining, the staff is there, they should have a preceptor with them. Those they will be with them only, and those will be guiding the new joinee to give the medication, because it is something which is not at all acceptable. So after 1 month of training, we can again check the evaluation. And the study has also mentioned, because we need to check the evaluation and see the impact also. Like in this study, it has been shown that after the bedside audit, after the training and bedside audit, it came to know that the staffs, they got so much of improvement. Like if we can see before and after, the documentation errors reduced from 18% to 4%. Infusion rate errors were reduced to 7 to 1 per month. Then double check missed 32% to 3%. Confidence score was increased in the staff nurses. So 4 basic things we need to talk on, that the staff also has to be assertive enough to escalate the matter. So first, speak up. So if prescription is unclear, please clarify. Never assume that it is 0.4. Okay, it can be 0.4 or it is 4. Don't assume, just clarify. Second is report near misses. So you yourself should have that thing in your mind, that if suppose something I have missed out, just tell it to the in charge, so that the things can be discussed and briefed out in a briefing time, and that can prevent future harms. Then no distraction zone. Like we have different medication preparation areas we can have. Like especially for concentrated electrolytes, we have different preparation areas. There we can prepare the medication and calculate the dosage correctly to prevent any kind of wrong calculation. And then 4 eyes principle, especially in cases of high alert medication, pediatric dosage calculation, and chemotherapic medications. 4 eyes means 2 people. So 1 people, 2 eyes, 4 eyes principle, both will be cross-checking each other, and at last we can have the sign by the senior staff nurse. So these are the various strategies which we can make it out to prevent the medication errors and infusion rate errors. Kumkum ma'am also has given one more strategy, that we can help the staff by giving them the rate, and as per the ml per hour we can give them the drop factor, so that it will be easy to take it as a reference point, so that easily they can administer the medication. So at last, I would like to say safe medication administration is not an act, it's a habit. So we are acquiring the knowledge, but we need to have that accountability in us. We need to have that confidence in us. And the confidence will come only when we'll have the knowledge and skills. And as a trainer, we should know how to develop that knowledge and skills with the help of knowledge test, OSCE-based guidelines, and then written demonstrations after demonstrating all the procedures from the staff nurses, and it all together will lead to the patient safety. So competent nurses will deliver the safe medication and infusion practices that will save lives. Thank you so much.
Thank you, Pooja, for this wonderful deliberations. I think you've covered and touched upon all the safety checkpoints in such a short span of time. And I really liked your framework on 5 rights and 3 checks, which is also being backed up by the research findings, which where you mentioned from 9% it has become to 1.2%, which is commendable. And I also liked your last research findings where you kind of put the frameworks into your practice. So it's evidence based data that you've presented today. And I would like to also mention here, adding on to what you said, that according to JCI, nurse is actually the last person or the last barrier who can actually prevent the error. So it could be a prescription error, it could be a transcribing error, it could be a dispensing error. But if there is one nurse who is um, knowledgeable and is assertive, confident to voice out the red flag, she can prevent it. But if she also misses out, then there is no way out. It's a cheese model, right? So thank you so much, Pooja. I think it was very, very enlightening. Thank you. Great. So with this, we've come to the end of our panel discussion. But before we do that, I have some interesting, takeaway messages for our young nurses, and we kind of, have a rapid fire, round where I would request our panelists, to pitch in and maybe can voice out their opinion on the question that I'm going to just put up now. So, and this is open to any of the panelists. So, one infusion practice every nurse must do without fail. This question can be answered by any of our panelists. One infusion practice you think that every nurse must do without fail. Miss Vidya, Miss Priyanka, any one of you?
Hand hygiene.
That's correct. So there is no right and wrong. It's just I just want people to take away those messages, right? One unsafe practice that has to stop today.
Assuming.
Assuming. That's right. And also, I think recapping also is something that people are aware, but still they tend to do it. And one thing a leader can do tomorrow, or they should start doing it right away, doing encourage infusion safety. Anything that you think will be helpful. Anything that the nurse leader should start. Maybe a system of self-reporting and kind of having a recognition of those nurses who are doing self-reporting, or maybe have some awards. I'm sure many of you are already having the safety brand champs where the nurse intercepts an error, something which is so most often than not we tend to reprimand or question nurses who make mistakes, but we don't give due recognition to the nurses who actually intercept or prevent the errors, right? Good. So with this I think with the paucity of time, I would probably now will not be taking any more rapid round questions, and I would like to close this panel discussion now. And I leave you all with a thought that is, in infusion therapy, every drop matters and every nursing action matters even more. To the patient, an infusion can be, a life-saving procedure. To the nurse, it is a moment of real clinical responsibility. And to the organization, it is a mirror of how strong our safety systems truly are. So patient safety is not a department, it is a behavior. So let's lead the way, strengthen the standards, build the competencies, speak up for safety, prevent the infections, and make sure every infusion is delivered with knowledge, skill, compassion, and accountability. Thank you to all our wonderful panelists, our organizers, and every one of you for being part of this. Thank you so much. Thank you.
Thank you so much, ma'am, for the for such an insightful discussion and taking out the maximum for the audience from the panelist. It was indeed a very, very, very interesting session. We would be quickly moving on to the next part. Those who have been off and on, we have completed the panel discussion. Now we are moving on to the next part, which is the very smart QIP discussion with my Miss Hemanti from Vedanta. Post that, we would be having the open forum session. You may put your questions in the chat box or in the Q&A box. The team of experts would be answering the questions, and directly we can expect the answers that you want in there, and that would be followed by the vote of thanks, officially closing the session. So I would like to invite Hemanti, a young budding nurse. She is from Medanta, and she is representing nursing quality here, and she'll be here with the QIP. Hemanti, over to you.
Thank you for the opportunity. And good evening to everyone. Good evening to all the healthcare leaders and my fellow quality champions and everyone. Myself, Hemanti Chaudhary from Nursing Quality Team of Gurugram, Medanta. And today I'm here to share one of my success story of Medanta by presenting the Project Prism. So every day over 1,000 of cannulation has been done in a hospital, in any hospital, not only in Medanta, in any hospital. But it is also a very most invasive procedure that has been done in any healthcare setup. That could be a minor setup also, that could be a major setup also. So not a long back, but in the June 2025 in Medanta, we have our data, and that has told a very huge story that we couldn't ignore, and that is only 50% of our IV insertion were being done on the first attempt, and the phlebitis rates are also high as per the NABH benchmark also. So that was the time when we have decided that we have to take a change on this situation and we have to improve in this time. So here I am proudly presenting my success story of Project Prism, and I'll share my slides also. Is it visible to everyone?
Not yet. You may want to put it to the slides. It's not visible.
Okay, just a minute. Now?
No, you may want to move to the screen which you want to share. Just do it, try again. It will be coming.
Okay.
Just select the screen where the presentation. Just open the presentation. It will be visible.
Yes, it's already opened in my window, but
Okay. Let's try it once more from your side. Yes, now it is visible.
Okay. So here I am with the project Prism. This is all about the phlebitis reduction and IV skill mastery. And let us move to the background of this project. So before we discuss about our success story, let us discuss why we have take this project as Project Prism. So the main reasons of the high phlebitis rate impacts in our patient safety. Second, the risk management gaps in IV cannulation all over the hospitals and the variable staff skills levels. And also this IV cannulation has a direct impact on all the patients' experience that is being admitted in the hospital. The objectives, what we have decided or what we have seen is to implement the best evidence-based practices in IV cannula handling. Second, to enhance the practice of assessment of IV cannula site by using the VIP tool, which helped in early detection of the complications. And the third is to improve the reporting of the phlebitis. When we have started our project, at that time, the project CTQ identification, what we have identified are mainly first the accurate documentation of the PVA complications, and it should be documented by all the baseline staff because they are the only staff, they are the only person who is assessing the patient each and every time 24/7. Also, all the cannulation data must be documented properly. Second, the staff skill competency, timely assessment of the staff skills and knowledge, and the OGT regarding the IV cannulation and the PVA complications. And the third is the phlebitis reporting. As earlier I have said already that all the phlebitis must be reported timely and the early identification must be done on each bedside. Next, this is our baseline data when we have started our project in our Medanta. So here you can see the accurate documentation was 72%. The dressing compliance also is very less, 56%, and the PVA complications are 68%. What we have set as a 90% of benchmark to achieve in this year. This is our pre-project compliances. Like on the month of June 2025, we can see the phlebitis are 56. And then it goes on the 64 and 79. It was increasing. And there we have decided that we have to work on it. And the first attempt cannulations are also huge. Like among 1,675, we can only see 807 cannulation will be done in only the first attempt. On the same was also in the month of July and the August also. So to rectify all of this, we have started a audit that will be done by all the nursing supervisors or the quality team and the IV cannulation team also for the patients in the each bedside, where we will check the patient cannulation status, the patient current cannulation status, the previous status, and the articles, what is been used for the cannulation, the process, how they are handling the cannula of the patient, each and everything. So let us move to the defined phase of our project, where we have decided our project on the month of June, 1st June of 2025, and we have an estimate date of the March of 2026. Then we have measure our compliance or non-compliance in the phlebitis reporting in our hospital. There you can see that in the month of June, it was 71% and gradually to the August 72 and 86. As we have started our training program and in August, we have identified this problem. We have already started to working on it. So it has been increased as 86, 84 and thereafter 83% in the month of October. The cannulation on the first attempt, same on the June and July, August, we have get a very less data. It's like 48%, 53% and 49%. In August, we have started our simulation-based training for all the staffs all over the hospital. And that's why it's being increased as 63 and 64% on the month of September and October. In the analysis phase, by having all the data all over the hospital, we have planned a fishbone analysis where we can find out all the main reasons which can be lead to the 90% of these critical situations. Like On people, we can see the casual attitude or negligence by the staff or the lack of the management system. And the second, under the policy, we can see lack of awareness or SOPs and outdated knowledge, no monitoring sometimes. On the measure, we can see no reporting of the phlebitis, less reporting of the documentations also, and no effective RC and kappa of all the phlebitis that has been happened in the hospital. In management also, there is lack of improvement, there is lack of project also, no risk management was also been happened. So this is the mainly major 4 points which we are focused to get improved. Other than that, there is a factor of material and environment also. In improved phase, what we have focused was the people management and the measurements. For the people, we have started the training program, and the supervision is being strengthened. Like in the bedside, if the staffs are doing any kind of cannulation, there will be any supervisor, either the supervisor or the IV cannulation team or the quality team will monitor the staff and help the staff to do the cannulation properly. Initiate the process audit more actively. And other than that, we have started our training program also for the staff to improve their skills on the IV cannulation. This is our training data where we have mainly focused on the staffs who are fresher in the system, like the fresher staff who don't have any kind of experience on cannulation. We have monitored that majorly the cannulation problems or the less skill are being identified for the fresher staffs only. So we have 243 staffs, fresher staff, among which we have started to do assessment test in which we can find only 26 staffs are competent. Other than that, 217 staffs are not enough competent or skillful for the cannulation. And we have provided a skill and the simulation based practices for them. So our training programs were being scheduled like first we have identified and selected the staffs who are having this kind of errors, like in which shift we are seeing that the staff is not competent for the dressing of the cannula or handling the IV cannulation process. Thereafter, we have done the pre-test sessions to assess their knowledge and skill levels. And after that, we have started our hands-on training, simulation-based practice and training. And other than that, after we have done also the post test of the staff. If the staff is being in the post test, if we see that staffs are already gain a skill or they have already gained confidence for the IV cannulation, we have give them rights for the IV cannulation. Other than that, if the staff is being failed, then again we have provided training for the same staff. Then let us move to the control or sustain results. By giving the training and audits or the regular monitoring, it is being improved a lot for the phlebitis also. As you can see in the month of June, when we have started, it was 56 on the month of June, only 56 phlebitis were being reported, where it has been increased like 79 on the month of August, and December also 75. And thereafter, we have started the training program and continuous monitoring. Because of that, it is being reducing to the 37 on the month of March 2026. Then the first attempt cannulation compliance was being also increased in our hospital. Like in the starting of this project, it was been 48, 53, and 49%. And after giving the training and continuous monitoring or helping the staff through the IV cannulation team, it has been increased to the 98 and 95%, where we have set our benchmark as 90%, but we have gained more than that. And the last point, but not the least, the benefits what we have get is increased staff awareness on IV cannula handling practices through the classroom and hands-on training, and enhance the practices of the assessment of IV cannula site by using VIP tool, which helped in early detection of the complications. And pain-free IV cannulation improve the reporting of the phlebitis or the early reporting of the phlebitis. So this is all about my project, what we have achieved in Medanta. And thank you. Thank you very much.
Thank you so much, Hemanti. It was really a very different way, and yes, thank you so much. So let's move on to the next part, which is the open forum. So we are a little bit running short of time. We have taken an extra 15 minutes already, but there are questions which have come up in the Q&A box. I have received it through a DM, so I can just take up the questions. They're quite interesting that we've got. So I've mentioned the city name from where I have received that. Anu ma'am, with your permission, shall I read the questions?
Yeah, please go ahead, Pooja. Yeah.
Okay. Yes. So the first one is this from Chennai. If a hospital has limited resources, what are the top 3 interventions that can make the biggest difference in infusion safety? Hemanti, you can unshare your screen. So, is the question clear? Like, hello? Hello, is it audible?
This question is for whom?
The question is for any of you can answer this question. It is open
Actually,
itself.
what I feel, if you're limited resources and all, so one thing I have already showed in my presentation itself, you can provide some of the ready reckoner for the nurses and repeatedly on-site round during your on-site round, correct them at that same point with a positive feedback. Always we should not just put them into the blame game and just try to rectify them on ground and try to solve their problem. What is the correct way, what is the correct thing, how you can do it, just on site training will help the uh, give proper results. With the shortage of even your resources are shortage and all, whoever is taking down the competent person, the person should be competent enough to just talk to them with positive rewards for the next time.
Right. Thank you, Kumkum ma'am. The next one is.
I think I would like to add up
Yeah,
here.
ma'am.
I think very valid point. See, when you have limited resources, the best thing is what you can try to do what is in our hands, right? So one of the thing is the ready reckoner, the flow charts, the checkpoints, the checklist that can be created. Second is I also like this, the 5 rights and 3 checks. It's something, a very very simple innovation, but it is not dependent upon the resource. It is something that the nurse will have to do it by herself, but can significantly reduce the the, I would say, the incidences of errors. And what we talked about is the competency building, and this is my urge to all the young nurses who are listening out here. Most often than not, we see that once we graduate or we complete our nursing, we don't study much. So I think learning is a constant I would say journey, and it is not only going to be dependent upon hospital taking your classes. It's completely in our hands. We have the books, we have now the social media is flooded with the nice snippets of information, booklets, reading material. I think if you are keen to develop yourself, how much constraint your unit organization is, but you have the power to make changes in your ways of practice. Yeah, thank you.
Thank you so much, ma'am. This is one more question where we'll be needing insights from Ms. Pooja and of course Anu ma'am from your side as well, which is this is a question which has come from Asansol in West Bengal, and the question is, how frequently should infusion therapy assessment be conducted to maintain the high standards of practice?
Yeah, so actually, it depends on the hospital wide also. Like in our organization, we are doing it at the time of joining when the staff is joining. Then after that, we are having the preceptorship program. So there we have a preceptors which we are which actually we are giving as per their competency to the new joinees, and they are training them with them. So whenever they are going to the patient, they are taking them together, they are involving them in all the care, and it is continuing till 1 month. So what we are doing is after 1 month, then we are having our one knowledge and skill based test for these staffs. If they are okay, we start giving them some competencies and privilege with assistance, not fully granted. And after that, we are doing 3 month assessment for the competency, including this IV infusion and IV safety and medication administration as well. So after that 3 months, if we find out there are still some training need points still which are pending, we give on training. And after that probation timings, when it is going to complete, again at the 6 month, we are doing the competency assessment. And accordingly, we are doing the confirmation also of the staffs, and we are giving the privileges as granted for medication administration and IV safety. And then after 6 months, when we come to know, then okay, the staff is doing nice and the staff is competent enough, then annually we are just retraining them, and annually we are doing the competency assessment. So we are doing 0, 3, 6, and then annual, like that.
Yeah, I think I'm in agreement with what Pooja said. I think that's the prescribed format, and also just to add on, if there is any department change, right, then it will be on the basis of, for example, I'm working in say an OBG department. I'm being shifted to, say, for example, I've done a basic infusion thing, but I'm being moved to a chemo department. Then it will have to restart, right?
One last question, ma'am. This is from Jammu. We've got a good reach in Ivy Talks. We have people right from the top of to the at southernmost tip. So Jammu, we are having a question, which is, if a nurse identifies an error before it reaches the patient, what should be the immediate priority? Reporting, documentation, or corrective action?
So, see, I didn't understand the corrective action, because in this particular case, first of all, the error did not happen, right? I think the first thing, in my opinion, should be reporting to your seniors. And for example, it's a prescription which is being, written wrong, right? Then, obviously, keeping your seniors informed, and then, getting it to the right doctor. And because I am sure most of the hospitals also have a mechanism of incident reporting. So they will also have to raise an incident report for a wrong prescription, because every incident has to be reported, even if it is a near miss, right? So it will fall into that category. But reporting, then getting it correcting, and then obviously delivering the care.
Right. Thank you so much, ma'am, and thank you for all the panelists, and of course, our QIP presenter, Ms. Hemanti, for the wonderful discussions and very insightful and very much knowledgeable session that we had today from all the domains. We slightly have increased the time, so the audience are dropping in. But let me make it sure that this the entire recording would be available on the INS India platform. We have already posted that. So month on month, the Ivy Talks, you can see the recording of the entire session from the INS India official website. You log into INS India, go to Ivy Talks, you can see all the sessions over there, right? And many of the people are attending this in big groups in the hospitals. So in the nursing colleges, they are attending it in a big conference halls and all. So that and all, we are getting a lot of pictures, quite exciting. I would like to invite Josephine ma'am, Governing Council member, INS India, for concluding the session with the vote of thanks. Josephine ma'am.
Hi. Can you see me? Good
Just
evening,
We can hear
everyone.
you.
ma'am.
We can only hear you.
But you can't see me. Why? Pooja, you take care of that.
I am trying, ma'am, but I think your
Okay,
camera.
okay.
Yeah, yes.
I think now. Okay. So good evening, everyone. And congrats to all. You all found time from 3:30 to 5. And I was just going through the topics. They are so interesting and so thoughtfully chosen topics. And the last session, the QIP, and just prior to that, half of it I could listen. And well moderated, Anu. I was just appreciating, you found time at that senior position and coordinated everything, got everything smoothly happening. So, Pooja, thanks for connecting
Thank
me.
you.
It was a big challenge to open my site only. So, thanks to INS for making these training forums happen. Ivy Talks, I know I was never part of this Ivy Talk, neither I could talk nor I could attend. I'm sorry. because of the time schedule, because it's very difficult to take out time during these busy hours. But it's a great learning for all of us, and especially the young ones who are aspiring to learn and master the skills of infusion therapy. And just 2 lines in my own experience. Earlier I wasn't also aware of this beautiful textbook which is available on infusion therapy. I read it, learned it years back, and made the standards happen and got this organization where I'm working certified. And all of us could feel the difference from the base. We have come to a higher level. I'm sure all of you are going through that experience. It's really wonderful to have infusion therapy standards getting implemented. So INS has given a great forum to all of us, organizing this beautiful session, leading the way infusion safety, nursing practices that matter. Thanks, Anu, once again for moderating the session so successfully. And I'm looking at all the speakers. Dr. Farhan Nain, Senior Consultant Hematology and Bone Marrow Transplant at Max. Sir has spoken on high-risk medications in hematology, their safety considerations during infusion therapy, and the multidisciplinary approach. We all know that, especially in infusion therapy, and especially he is in bone marrow transplant unit, multidisciplinary comes, very, very significant. So thanks to Dr. Farhan for the topic which he has presented well. I'm sure everyone learned from his talk. Then, of course, thanks to Miss Kumkum Ghosh, GM Nursing and Paramedic Education at Agarsen International Hospital. You spoke on creating a culture of safety, leadership strategies for infusion and medication and infusion safety. I totally agree with you. A very chosen topic. Even if we have everything in place, is always a challenge. Anything going wrong, the leadership is questioned. So keeping things in place, policies, protocols, ONUs in soft copy or hard copy will not make it happen. It has to be really implemented. So leaders have a huge role to play. And interesting topic. Thank you, Ms. Kumkum. And then we have the ICN BT Siji. I think she's from Fortis Noida. She spoke on preventing infusion-related phlebitis through standardized practices. Very important topic, because standard precautions and standardized practices, though we learn many times, we don't practice it. So thank you, Vidya Siji, for speaking about that topic. Then I can see Priyanka Kumari, specialty nurse from Medical Oncology Fortis Hospital. She has spoken on medication safety checkpoints before, during, and after. So very important topic. This is what we miss at times. Though we start the infusion properly, calculated it correctly, then the monitoring and documentation part and the patient education. I think she might have covered that. Thank you, Ms. Priyanka. And Pooja, I know Pooja, we quite often we meet at Sarvodaya because my good friend is there as director nursing. So you are into academics, informatics, and admin. Big challenge in front of you as well. And I totally agree with you. We have to keep checking. You are checking competency at, you are suggesting preceptorship followed by 3rd, 6th, 9th, all these regular intervals, updating them. I think the best is simulation, actual hands-on training on simple cannulation to computing, using the equipment, selecting the device, selecting the site. Even someday they find it, especially a very good project I can suggest to Pooja is DIVA project, difficult intravenous success, because we all study on routine cannulation and success rate. We should now focus on with more and more comorbid patients are coming, oncology and CKD patients, very hard to find a way. I think DIVA project something which for academics, since she is heading that department, we are taking it as a project now. There are companies, industries who are sponsoring for that, but they have a very good module and we can take it forward. Maybe INS also can think about it in future. Thank you, Pooja. Anyone I missed? I don't think I missed anyone. Pooja, Kumkum, I thanked, Farhan, and Miss Priyanka, Miss Vidya, and last the young girl, Hemanti Chowdhury. Excellent phlebitis reduction presentation and mastering the skills. I think again, mastering the skills, I know you will agree with me. Difficult in a success. Every patient want only one prick. And
That's right.
that's a huge challenge in front of the youngsters. And one thing which I noticed lately, the number of, they know what is infiltration and extravasation, vesic and non-vesic and everything. But the number of extravasation at times goes up. The clinical challenges and the litigation in future and the patient safety, big question mark, comes with extravasation. We may have to sensitize the nurses more. I have a feeling. So I think she has put it very nicely how we have to take care of phlebitis. So I'm not going to speak more. I think I spoke enough. Thank you, each one of you, and thanks everyone for preparing the topics thoroughly. And these are difficult topics and very important topics. And you took time and educated everyone, spoke beautifully, prepared the presentation for everything. Thank you. Thank you, Anu, once again. Thank you, Pooja Swaroop.
Thank you, Ms.
And thanks,
Prasuna.
INS.
Thank you.
Goodbye and happy infusion journey with one quote from my side. Infusion therapy is not about the IV line and the drug. It is still about the right patient, right drug, right dose, right route, right vein, and the right device. It is all that rights that is still we need to practice with a lot of empathy and compassion. Thank you.
Thank you. Thank you.
Thank you. Thank you so much, ma'am. Thank you to all the audience for patiently listening and for the active feedbacks that we have been receiving throughout all the questions. Thank you to all the panelists. Thank you, Anu ma'am. Thank you to all the nursing leaders, all the INS leaders here in Delhi NCR chapter, Lavleen ma'am, Minati ma'am, and of course, Lekha ma'am. And thank you, Josephine ma'am, for after
Thank
so
you,
much trouble
Lavleen.
joining in.
I missed her. Thank you, Lavleen, who coordinated with me. Thank you.
All right. So the next IB Talks is hosted by the Gujarat chapter. That would be quite interesting. They are hosting the INS annual conference also this year. That would be in the month of July. Stay tuned for more information. The recording of the content, again I repeat, would be available on the INS India website. Click INS India. You go to the IB Talks and then attend the webinars over there. And there's a feedback form in the link in the chat box. Please do complete that. Thank you. Thank you so much.
Thank you, Pooja. Thank you, Josephine.
Thank you, ma'am.
Thank you. Thanks all the panelists, audience. Thank you.